Dr. Schemitsch is chair of the Department of Surgery at the Schulich School of Medicine and Dentistry. He is also head of surgery at both the London Health Sciences Centre and St. Joseph's Healthcare London. He is internationally recognized as a leader in the field of fracture repair and musculoskeletal trauma, particularly in the management of hip fractures and joint replacements. Throughout his career, he has advanced the use of evidence-based medicine in surgery and led numerous clinical trials to improve care for patients with orthopedic injuries. His work has had global impact, shaping surgical protocols and improving patient outcomes in hospitals across Canada and indeed around the world. Dr. Schemitsch is a dedicated educator and mentor, widely respected for his commitment to training the next generation of surgeons. Please join me in welcoming Dr. Schemitsch.
Good afternoon. It certainly is an honor to be here today to give this distinguished university professor public talk. I think Aristotle said it best. It's the mark of an educated mind to entertain a thought without accepting it. Clinical research is the process that allows one to distinguish between information and evidence. So why is this important in orthopedics, and why is this important with respect to musculoskeletal conditions? Well, musculoskeletal conditions are the leading cause of disability worldwide. They're the #1 cause of absence from the workplace. They're the second most common cause for consulting a doctor. They're the highest direct cost to the Canadian healthcare system, and they cause significant pain, diminished function, and quality of life for patients. So I've been fortunate to work here at Western, and the elements of Western that really facilitate my doing research are the outstanding and sustained commitment to MSK research and education. There's an incredible depth and breadth of talent in terms of trainees. We get fellows from all over the world. We have collaborators and partners who want to partner with us in doing clinical research. And there's a focus on transdisciplinary and team-based MSK research. I think if you're going to do clinical research, the most important resource is a collaborative group of investigators. And over the years, I've been very fortunate to be involved with a number of different groups. For me, the ABCs of research are to always be collaborative. And primarily, the Canadian Orthopaedic Trauma Association, which I'll speak to in a moment, and a number of other groups and international networks have facilitated the clinical research that I've been involved in. This is just a group photo of the Canadian Orthopaedic Trauma Association. It's a group of clinicians, methodologists, researchers, research coordinators who basically get together and plan, implement, and undertake clinical trials. This is our most recent meeting last year. This group is currently involved in more than 30 randomized controlled trials and prospective cohort studies. And pretty much every one of those we're involved with in London or leading. So how can impactful research be done? Certainly in terms of clinical research, I think it's really critically important to find common problems. So we tend to focus on things like hip fractures, ankle fractures, wrist fractures, and proximal humerus fractures. It's really critically important to evaluate basic techniques, and really critically important to always collaborate and pick the right mentors. As a result of being in this group, we've been very fortunate in terms of producing some landmark studies that have been published in some high-impact journals. This is an example of one where we looked at total hip arthroplasty or hemiarthroplasty for hip fracture. Another study that we recently published, which is the largest trial published to date on intertrochanteric hip fracture management, where we looked at 2 commonly used devices. This is a study that really changed the management of distal humeral fractures in terms of managing the ulnar nerve. This is a study that changed management with respect to the management of flail chest injuries in the ICU. And this final study is a study that was published looking at hip fractures, specifically femoral neck fractures with 2 commonly used implants. So RCTs can really help determine efficacy of treatment. Challenge, though, we've learned over the years is that RCTs aren't always the way to go. So when do RCTs make sense? Well, when the prognosis and predictors of outcome are well understood, when there are no flaws or biases in methods for selecting and randomizing patients, when you have straightforward management options, and when expertise is a lesser issue. The challenge, though, is that you do an RCT and sometimes it doesn't change practice. And the question is why is that? RCTs were developed for drug studies, not necessarily for surgical trials. Sometimes they're not ethical or feasible, so if you're going to do a study looking at impact of time to surgery, it's hard to randomize patients. Outcomes can be rare, and there's often a lack of equipoise. There are also difficulties if there are flaws or biases in selecting and randomizing patients, and expertise in surgery is a huge factor. So you have someone who is really highly skilled and highly trained versus someone who's less skilled and less well trained. Are the outcomes due to the surgery, or are they due to the person that's performing the surgery? Feasibility is also an issue for the following reasons. And as a result, surgical trials aren't big enough. So if you look at the average surgical trial, it's around 90 patients. We've done some work that shows that when you do a trial of 90 to 100 patients, the results are often very fragile. And it's not until you have an order of magnitude more patients. So if you're doing more like a pivotal trial with 1,000 patients, you really get a result that is stable. And RCTs, as a result, haven't always given us the answer. I'm just going to go through the proximal humerus fracture, an area that we've done quite a bit of work in just to show this. So there have been a number of RCTs done in this area. And there's a lot of interest in this area because these fractures are common and they have significant impact. If you look at the evidence in 2025, despite the fact that it's been a plethora of randomized controlled trials, there's little evidence to support fixation of these fractures. And yet we know that when someone breaks their shoulder, the patient often benefits from surgery. So it's really challenging to figure out why it is that some patients benefit and others don't. So if you have an RCT that tells you that surgery makes no difference, does surgery really have no effect? So, we've done quite a bit of work showing that really people can't do an RCT in an area where you don't understand prognosis and predictors of outcome. So if you can't agree on what actually determines prognosis and predicts outcome, it's really challenging to do an RCT. There's also a lack of agreement on the classification of these injuries and the ideal outcome measures. Management options aren't straightforward, and expertise is extremely important. We've also learned that it's really critically important to understand current practice and predictors of outcomes before designing new RCTs. You need to understand patient fracture and treatment factors in determining outcomes, and you need to understand why some patients are regularly excluded from RCTs. So that's really led us to focus a lot now on registries and prospective cohorts. So registries are ideal because they give you population data, and they are potentially something that you can use AI and machine learning algorithms with, and they'll enable you to actually develop novel risk prediction tools which actually help the clinician at the bedside. Prospective cohorts, I think, are going to play a large role, and this is something that we've actually been leading in. So the advantage of a prospective cohort is that you can observe the effects of different interventions on outcomes as they occur following the intervention. You can look at a large and comprehensive set of relevant variables. It allows you to look at greater heterogeneity of treatment in patients, and it can address some of the limitations of RCTs. And a big advantage is that feasibility is improved. There's no randomization, clinicians can treat as usual, and the cost is lower. So if you're looking at a prospective cohort, you can examine multiple treatment comparisons, you can focus on multi-dimensional outcome assessment, and these studies tend to have higher external validity. And I think what's really critically important is they can complement RCTs. So at the Canadian Orthopaedic Trauma Association now, we had traditionally focused almost exclusively on RCTs, and now we're transitioning into doing many more of these prospective cohorts. And what they enable you to do is to establish the questions and hypotheses for future-focused RCTs. So to actually identify the patient population that might benefit from surgery, for example, in the proximal humerus, that would then allow you to do the RCT in that area. So I'll just give you a couple of examples of some cohorts that we've designed. So this is the Decipher study. So it's a North American study, multi-centered study, where we're looking at almost 1,000 patients with proximal humerus fractures to determine exactly what impacts outcomes so that we can design the next generation of randomized controlled trials. This is the WARE study that we're funded for to look at over 3,000 patients waiting for hip and knee replacement. And again, this study is going to be critically important in terms of the management of patients with hip and knee arthritis. So So it's an observational study with a goal to determine how wait times for total hip or knee replacement affect people with osteoarthritis. It looks at examining how non-surgical management options help people waiting for hip and knee replacement. And I think it's going to change public policy because it's going to allow us to actually optimize waitlist policies. So the primary aim of this study is to identify which patients are more affected by longer waits and how inequities, because there's no question in people on wait lists, there's massive inequity in terms of who actually gets surgery in a timely fashion, and how that affects the progression of symptoms prior to and recovery following total joint replacement. So if you're waiting longer, does that actually have a negative impact in terms of your outcome? So I think the bottom line I've learned is that sometimes RCTs are not feasible, ethical, or practical. But that doesn't mean we shouldn't be doing RCTs. So we should be doing prospective research, and that can include RCTs, can include prospective cohorts, and include prospective registries. Well-designed prospective cohort studies may be better able to make generalizable conclusions versus RCTs, and well-designed prospective cohort studies are necessary where RCTs have significant design issues. So for example, in the proximal humerus, distal radius, and in the pelvis. So in conclusion, I think it's really critically important to study common problems to have an impact. You want to have adequate sample size, so I think it's absolutely critical when you're doing clinical research to collaborate. So important to have networks, not just in Canada, but in North America and around the world. Infrastructure is critically important, as is expertise in doing these trials. You really need to understand prognosis and the predictors of outcome. I think surgical RCTs tend to be helpful when prognosis is well understood. There's no selection bias in randomization, and expertise is less critical. And I think there's an increasing role for well-designed prospective cohorts for decision-making and generating hypotheses for RCTs. And Western really has been a leader in this area, so that's super, super exciting for me. So just finally like to thank my family, without the support of which I would not be here today. My wife Maureen, who's in the audience, and then 4 kids, Laura, Jeffrey, Christine, and Thomas, and they make going to work every day worthwhile. Thanks very much.